And then let's move on to vertical position. Until now, we talked about horizontal position, the bucco-palatal position of immediate implant. And then vertical position, apical-coronal position of implant should be considered. As shown in this research, implant cannot hold the bone, so horizontal bone resorption will occur, and at the same time, vertical bone resorption will occur. So by placing graft material into the extraction socket, we can compensate the labial bone resorption, and also we can maintain labial tissue thickness around the implant. But this graft material or bone augmentation procedure cannot hold labial bone resorption, cannot prevent vertical bone resorption. So we should anticipate the vertical labial bone resorption and place the implant appropriately. So apical coronal position of anterior immediate implant placement should be completely different from normal implant placement. Depth control should be done properly. So when evaluating apical coronal position of anterior immediate implant, we can use these four reference points: CJ of adjacent tooth, marginal gingiva, and proximal bone crest, and labial bone crest. But I always use these two, marginal gingiva and proximal bone crest. CJ is a static landmark, but this CJ is not helpful in recessed gingiva. Only the patient with very healthy periodontal condition only healthy periodontal condition patient, the marginal gingiva is same as CJ. So not helpful in recessed gingiva. If there is some gingival recession, this CJ cannot be used. We will place crown on the soft tissue, on the gingiva. So this CJ is not so good reference in vertical positioning. So please use this marginal gingiva. Very, very good reference point. And also the most important point. And when placing implant after flap elevation to perform GBR, at that time, proximal bone crest should be used. But labial bone crest, sometimes, if some dentist want to place implant in type 1 socket after flap elevation, but as I said, flapless implant placement is much better. But if you want to open the flap to check the bone condition, when at that time, this labial bone crest can be used. Let's talk about one by one. CJ. This CJ should be used only when your patient has healthy periodontal condition. Only healthy periodontal condition. CJ is same level as marginal gingiva. So from the most apical portion of CJ of adjacent tooth to the top of implant, 3 to 4 mm, but I prefer 4 to 5 mm. So I think this is much better. Marginal gingiva, from the most apical portion of labial gingiva to the top of implant, this distance should be around 4 to 5 mm. 4 to 5. Here, from the top of the implant to the top of most apical portion of labial gingiva, because labial gingiva has scalloping. Most apical portion of labial gingiva should be a reference point. This distance should be around 4 to 5 mm. But you can use this implant driver, picture driver, when measuring the apical coronal position of implant, you can use this picture driver. But in just like this slide, if you can use this implant with mount, we can call this green portion as a picture mount. So when placing this implant with mount, you can use this anatomy from the top of implant to this area. This distance is 4. So this is 4. So you can place implant like this. Please remember this anatomy of picture mount. But if you want to confirm the apical coronal position of implant again, you can use this picture driver. Top portion of marking is 5, 4, 3, 2, 1. Maximum 5 millimeter. But when placing implant after flap elevation to perform GBR, at that time you cannot use marginal gingiva as a reference point. At that time, you can use proximal bone crest. From the top of proximal bone crest to the top of implant, 3 to 4 millimeter. This is my favorite distance. Here, when placing implant after flap elevation in type 1 socket, even though the flap surgery is much better, at that time, from most apical portion of labial bone to the top of implant, 1.5 to 2.0 millimeter, because around 2.0 millimeter labial bone will be gone after extraction because of bundle bone theory. Sorry. So please place implant as deep as necessary to make proper emergency profile of abutment. In this way, by controlling the emergency profile of abutment, this abutment can support the cervical gingiva. So we can maximize aesthetic, pink aesthetic. So deep implant placement is much better than shallow implant placement, especially in the anterior area. But by placing implant and by placing bone graft material, we can hold bone. We can compensate the labial bone resorption, right? But to maximize aesthetic result after first crown delivery, we should consider cervical gingiva, soft tissue collapse should be considered. So, can you see quite good cervical gingiva contour right after implant placement? How can you prevent collapse of this cervical gingiva contour? Right after extraction, this cervical gingiva start to be collapsed. Bone grafting is not enough to support cervical gingiva contour, right? Because we will pack the bone within the extraction socket. How can it hold this cervical gingiva contour? Same as before extraction. So I wanna introduce the modern concept of hard and soft tissue management. In the type 1 socket, if we can place implant immediately, if we can change the concept of bone grafting, we can hold the cervical gingiva contour easily with long-term predictability. So I wanna introduce that concept. As Dr. Professor Linda said, bone set the tone and the tissue is the issue. Because crown or prosthesis will be placed over the soft tissue, so soft tissue should be the issue. Dr. Salama, Stephen Chu, et al. Introduced this dual zone concept. After immediate implant placement, there will be a two zone. Bone zone, where the implant is placed. Over the top of implant, there will be a soft tissue zone soft tissue zone consists of cervical gingiva. Anyway, usually we pack the bone within the bone zone, right? But if we can pack the bone to the top of soft tissue, if we can place in both bone zone and tissue zone, we can maintain the cervical gingiva contour well with long-term predictability. So we can call this graft technique as a dual zone graft. Here, I packed the bone. In this case, in the thigh bone socket, immediate implant placement was done. Ideal palatal position. The gap distance was greater than 2, so I packed the bone inside the extraction socket. And also, deep implant placement was done from the most apical portion of labial gingiva to the top of implant 5 mm. This distance 4 to 5 mm, this distance was secured. And then when packing the bone, I packed the bone to the top of soft tissue, just below labial marginal gingiva and just below the papilla. Here, this is the CBCT after bone grafting. Can you see? This is top of labial bone. This is graft material. I placed the graft material over the bone zone. But even though we can pack the bone to the top of soft tissue, but how can it seal this soft tissue hole? Suture? After suturing, what will happen? Cervical gingiva contour will be collapsed. The main purpose of this dual zone graft is to maintain this cervical gingiva contour. So we should seal this soft tissue hole. How can it seal the hole? Healing abutment? As shown in this photo, healing abutment cannot seal the soft tissue hole completely. The cervical shape of natural tooth is completely different from healing abutment. Natural tooth has oval shape. Healing abutment has round shape. So we need another device. Provisional restoration. Yeah, this is a research about clinical outcome of anterior immediate implant placement. In group A, only immediate implant placement and small diameter healing abutment connection was done without any gap management. You can see the bone gap and soft tissue gap. Group B, immediate implant placement and provisional restoration to support cervical gingiva, to seal this extraction socket, at the same time to support cervical gingiva. Group C, dual zone bone grafting, and then wide diameter healing abutment connection. And group D, dual zone graft, and then to support cervical gingiva, this provisional restoration with ideal cervical gingiva contour. As we expect, group D showed best aesthetic result. At the same time, best minor bone resorption and soft tissue collapse. So I think this is the best way to save the bone and to save the soft tissue. Let's see in this case, because of carrier's crown was broken in left upper central incisor here. So a traumatic extraction was done with a periotom and implant positioning, palatal positioning, and depth control was done here. The top marking is 5 from the most apical portion of labial gingiva to the top of implant. I secured 5 mm, and then I packed the bone. TS3 is an internal connection type bone level implant. So bone graft material should not be inserted into the implant. So I blocked the inner hole of implant fixture with a fixture driver, and then I packed the bone to the top of soft tissue like this. And then with the ostem temporary abutment, I fabricated provisional restoration, screw retained type provisional restoration immediately, and then seal the hole. Anyway, let's see the vertical position of implant. Let's see the vertical position of graft material. Here, this is a provisional restoration. Screw retained type provisional restoration was connected to seal this soft tissue hole. And then 2 months later, there was no soft tissue recession. Because I packed the bone to the top of soft tissue, the graft material was buried into the cervical soft tissue. But it doesn't make problem. It didn't make any problem. It will not make any problem in the future because bone graft material itself has biocompatibility. If you can use the bone graft material with ideal quality and biocompatibility, no need to worry about this. This graft material can play a role as a pillar, not scaffold. From the beginning, we talked about filler and scaffold. To regenerate bone, we need scaffold. Bone graft material provides space for newborn regeneration, and bone graft material should provide some space for osteoblast adhesion. But when packing the bone graft material in the soft tissue level, this bone graft material should play a role as a pillar. No need to make a bone. No need to regenerate the soft tissue. Just the main purpose of this graft material, which was placed within the soft tissue level, is just pillar to maintain the mechanical stability of soft tissue. That's all. Here, and 3 months later, final prosthesis, final abutment was connected, and final crown was fabricated and delivered. In this way, I could maximize the soft tissue setting. So this is a dual zone graft. It's quite good concept. Panorama and PA. So I will show you some cases here. This is dual zone graft case in an immediate implant placement. Number 22, left upper lateral incisor. Here, as shown in the CBCT, the labial bone was quite thin, right? So type 1 socket. Yeah, let's see. Very thin gingiva biotype. So usually Asian patient has this kind of very thin gingiva biotype. Anyway, so I extracted this rootless with a traumatic extraction technique, and then implant was placed palatally to make sufficient gap, more than 2.0 mm here, from the inner extraction socket wall to the implant. This distance should be greater than 2.0 mm. And then next control was done. And dual zone graft. I packed the bone to the top of soft tissue, just below the papilla. And then this is Ostem temporary abutment to make a screw retained type provisional restoration. I made this temporary crown shell before surgery. After taking alginate impression, my technician could fabricate this temporary crown shell. After cementing this temporary crown shell to this temporary abutment, this cervical zone should be controlled by dentist on the chair side to support cervical gingiva well. So after cervical contouring with flow of resin, this provisional restoration was connected to the implant to sealing the hole, and occlusal view here, the CBCT. Can you see? This is a genogenic, low temperature treated genogenic bone graft material. This is a pre-existing labial bone top, but I packed the bone to the top of soft tissue. Let's see the longevity of this graft material. Even though this graft material was not placed within the bone, this bone graft material could be maintained because this graft material has biocompatibility. Let's see the long-term follow-up. 2 weeks later, soft tissue healing. I didn't open the flap because this patient has very thin gingiva biotype. And also, this patient presented type 1 scab. So I didn't open the flap. I didn't suture. I just sealed the hole with provisional laceration. And then 3 months later, final prosthesis was fabricated and delivered. Can you see the graft material buried into the soft tissue? This graft material can play a role as a mechanical filler. Final prosthesis was fabricated and delivered, and occlusal view, and 2 years follow. During 2 years after crown delivery, after surgery, there was no gingiva inflammation, no infection, no gingiva fistula. Yeah, this is a 2 years follow-up CBCT. Yeah, this is a pre-existing labial bone top, but the graft material, bone graft material, was being maintained very well, supporting the cervical gingiva. Here. So I think, in my opinion, this dual zone graft method, dual zone graft can prevent, can compensate the vertical bone resorption of labial bone. I think can compensate. Immediate post-op, 2 years follow. Here. 3 years follow, panorama, and clinical photo. Can you see? The papilla maintenance was successful. And then 3 years follow-up CBCT. Again, as shown, the genogenic bone graft material, which was placed within the soft tissue level, was being maintained well. So in this way, I could maximize the aesthetic result of implant prosthesis. Let's see one more case. 70 years old female patient, same side, 2-2, left upper lateral incisors. Here, broken, fractured. So I decided to place implant immediately because this patient had type 1 socket, sound soft tissue, and sound bone. Here, I could compound the labial bone in the CBCT, but what's the problem? As shown in this CBCT and photo, this patient presented severe labial version of upper anterior teeth. So there was very severe labial concavity. Can you see? So anyway, I placed 3.5 diameter TS3 implant. And so depth control from the most apical portion of labial gingiva to the top of implant. This is a 5 mm. 4 to 5 mm distance was secured. And then in this case, I used the PRP to make a sticky bone. I used the sticky bone because this patient is quite old patient. So bone regeneration capacity is lower than young patient. So to maximize the predictability, I used this PRP. So after mixing the particulated genogenic bone graft material to this PRP, I packed the bone to the top of soft tissue. Dual zone graft with this PRP sticky bone was done. And then here, because of very severe labial concavity, the implant apex was very close to the labial bone. As I said, at least 1.5 to 2.0 millimeter buccal bone thickness is required for long-term success. So I decided to augment the labial bone with this sticky bone here. So, but instead of full wide flap elevation, massive flap elevation, I used the tunneling technique in the distal side of implant in the vestibule area, in the alveolar mucosa, not attached to gingiva. Alveolar mucosa area, I made a vertical incision. And then I elevated periosteum, full thickness flap elevation around the implant was done. This is a tunneling technique. Like this, with the periosteal elevator. And then this is sticky bone, the xenogenic bone graft material mixed with PRP. And then I packed the bone underneath the flap, underneath the periosteum, covering the labial, augmenting the labial concavity around the implant. In this way, I plan to increase the labial bone thickness around the implant. And then, to make provisional restoration, I took an impression right after suturing with the transfer abutment. And then my dental technician could fabricate this screw retained type provisional restoration. In this case, unlike the previous case, I used quick temporary abutment from Ostem. Temporary abutment is made of titanium. Here, this is a quick temporary abutment from Ostem with thick plastic coronal portion. So anyway, we can maximize the aesthetic of provisional restoration. This is a quick temporary abutment. In this day, I prefer this one. 3 days after implant placement. Can you see? Because of PRP, I could get very fast and good soft tissue healing, even though I performed dual zone graft. You can see the epithelial tissue formation covering the bone graft material. So provisional restoration was connected to the implant. Yeah, 3 months later, soft tissue got healed very well. And also, you can see, yeah, this is a contour of soft tissue. You can see the graft material buried within the soft tissue, cervical gingiva. Yeah. So 14 weeks after implant placement, final prosthesis was fabricated and delivered. Yeah, panorama and CBCT. Let's see. You can see. Sorry. Here, this is a xenogenic graft material, sticky bone. Because the remaining labial bone thickness was quite thin, less than 1 millimeter, especially in the apical area because of severe labial bone concavity. So to augment the labial bone, I placed the graft material through the tunneling technique. So this graft material was being maintained well, augmenting the labial bone thickness. Yeah. So to summarize, type 1 socket, immediate implant placement is the best treatment modality. Horizontal position, labiopalatal position, palatal position of implant should be emphasized. You should make a gap between implant to inner socket wall, inner labial socket wall, more than 2.0 millimeter. And so the graft material thickness can be more than 2.0 millimeter. And also, vertical position of anterior immediate implant placement should be emphasized. From the most apical portion of labial gingiva to the top of implant, at least 4 millimeter. 4 to 5 millimeter is my favorite distance. And then to maintain the cervical gingiva contour, dual zone grafting should be considered. At the same time, after dual zone graft, you should deliver provisional restoration with appropriate cervical contour to seal the hole. This is my favorite treatment flow in type 1 socket. But sometimes we can consider socket preservation. In type 1 socket, I usually perform this socket preservation under the Pontic area. where the implant will not be placed. Here, this is the socket preservation. In Taiwan socket, immediate implant placement and dual zone grafting is best treatment modality, but underneath the Pantic base, to maintain the volume of extraction socket, underneath the Pantic area, artificial teeth area, we should consider this socket preservation. According to the surgeon, the graft material, preferred graft material was different. But as Dr. Sklar said, BIOS, non-resorbable genogenic material, is much better in anterior extraction socket. So in 1998, Dr. Sklar introduced the BioCore technique, BIOS plus collagen plug technique. We talked about characteristics of each bone graft material. Allogenic bone and autogenous bone. Human bone can be replaced by patient's own bone, but main disadvantage is severe resorption rate. But BIOS, how about BIOS? Genogenic bone. Genogenic bone, main characteristic of this genogenic bone is non-resorbable. So because of this non-resorbable characteristic, genogenic bone graft material should be a first choice in socket preservation, because the main purpose of anterior socket preservation is to maintain the volume. As we talked in the previous session. So I will show you the BioCore technique.
느낌은 있으세요?
In this case, 4 maxillary anterior teeth were extracted. I skip the extraction part. And then 2 implants were placed in both lateral incisor areas. Let's see the drilling and positioning. Because we don't have enough time, I'll skip the suture part. Yeah. And in both central and incisor area, I made a panting. But to maintain the volume, I decided to perform socket preservation. 2 transfer abutments were connected to make provisional restoration. In this case, to perform BioCore technique, apical 2 studs should be packed with genogenic bone graft material. Apical 2 studs. This is a low temperature treated genogenic bone graft material, just like AOS, BIOS. Pack the bone. And then coronal 1 stud should be filled with this collagen plug to prevent displacement of bone graft material. This is a particulated bone. And then to press down this collagen plug, cross matrix suture, buccal to lingual and buccal to lingual. This is the BioCore technique, BIOS plus collagen plug. Yeah, same. On the right side. Press down. And then, with the Pantic base, we should press down this area with the Pantic base to trim the gingiva. This is BioCore technique. But in my opinion, the main purpose of socket preservation is preservation of soft tissue architecture and volume, not newborn formation, newborn bone regeneration. So in terms of soft tissue healing, collagen matrix bone graft material, just like a BIOS collagen, can be helpful. So previously, I used this particulated by xenogenic bone and collagen plug. But in this day, if you can use collagen matrix bone graft material, just like BIOS collagen, you can use this BIOS collagen for socket preservation. This is BIOS collagen. I'll show you one case. Because collagen is quite good to regenerate the soft tissue. So in terms of soft tissue healing, so in case of open healing, collagen matrix bone graft material is much better than particulated bone because collagen can regenerate soft tissue. Collagen will absorb the blood. So each saturation, blood saturation is possible after placing this collagen matrix bone graft material. And over this exposed collagen matrix bone graft material, we can expect successful soft tissue regeneration because collagen will stabilize blood clot. Blood clot can be a scaffold for newborn formation, and over this blood clot, we can expect new epithelial tissue formation, just like an extraction socket. So let's see, in this case, I placed 3 implants in upper anterior area right after extraction. Yeah, after extraction. In this case, I used the OSTEM digital guide surgery system, one guide. Through one guide template, 3 implants were placed, and then prefabricated CAD/CAM abutment were connected. This is a advantage of digital guided implant surgery. Because implant could be placed same as planning, we can fabricate CAD/CAM abutment, custom abutment before implant placement. So I could connect custom abutment easily. And then here around the implant, dual zone grafting was done. I packed the bone graft material to the top of soft tissue. But in this case, I used BIOS collagen. Instead of particulated BIOS, I used the BIOS collagen. Low temperature treated xenogenic bone. And then here, right central incisor area and upper lateral incisor area. To maintain the volume of extraction socket, I decided to perform socket preservation with this collagen matrix graft material. I packed the bone to the top of soft tissue tightly. And then, with the Pantic base, I pressed down. I sealed the hole completely with the Pantic base. After adjusting the Pantic base, I pressed down. Prefabricated PMMA provisional restoration was cemented over the custom abutment. Here. TA. ADX later. ADX after implant placement. You can see beautiful soft tissue healing. Let's see the Pantic area. There was no labial bone resorption. Here, occlusal view. 3 months after, I removed the provisional restoration to take final impression. Here, can you see? Let's see. In this right central incisor area and left lateral incisor area, I placed only BIOS collagen without membrane coverage and without collagen plug coverage. But I could get successful soft tissue healing. Here. Also, by trimming the gingiva with a Pantic base, I could regenerate papilla. So, final prosthesis was fabricated and delivered. Here, like this. Panorama and PA. Let's see the CBCT. In here, as I said, I performed dual zone graft with collagen matrix bone graft material. Here, you can see the graft material which was placed within the soft tissue level, but this graft material was being maintained very well. Here, sorry, I will skip this. Sorry, I skipped this area. And until now, we talked about immediate implant placement and socket preservation. But let's move on to type 2 socket or type 3 socket. Sometimes we can do GBR right after implant, right after extraction. When the labial bone is gone, we should do membrane. So we should do GBR. But main disadvantage of immediate GBR after extraction is higher exposure rate of barrier membrane because of lack of soft tissue. So as we talked in previous sessions, we can overcome this lack of soft tissue by using this transmucosal GBR. You can use reservoir membrane or titanium mesh smart builder. We talked this in previous sessions. Fifth and sixth session, we talked about this. So I will just remind you about you of this transmucosal GBR with this case. One area. I introduced this case. I presented this case in the previous session. So I just introduced here. Sound soft tissue, right? But in the CBCT, their labial bone was gone. So this is type 2 socket. Sound soft tissue level, but bone recession. So in this case, we should do GBR because the labial bone is gone. So to regenerate the labial bone, we should exclude the soft tissue cell. So we should cover the graft material with a membrane. The bone graft material should not make a contact with soft tissue. So we should use membrane. So to use membrane, we should open the flap. Here I open the flap. And then immediate implant placement. In this case, we should use this proximal bone crest as a reference. In the type 1 socket, when deciding the apical coronal position of implant, we should use most apical portion of labial gingiva. From the most apical portion of labial gingiva to the top of implant, 4 to 5 millimeter distance should be secured. But in this case, I open the flap, so gingiva could not be used as a reference point. So from the top of alveolar proximal bone crest to the top of implant, 4 to 5 millimeter, 3 to 5 millimeter distance should be secured. Anyway, I placed the implant like this, and then in this case I used the reservoir membrane. I fixated this reservoir membrane with healing abutment after making hole and packed the bone. And I covered graft material with membrane and suture. In this way, we can overcome this lack of soft tissue. Panorama, PA, and CBCT. By placing implant in the palatal side, I could make a sufficient gap, so the thickness of graft material was greater than 2.0 mm. And screw retainer type provisional restoration was fabricated and delivered. Here, 3 months later, gingiva got healed very well. Here, you can see, when performing this transmucosal GBR, I placed the graft material as highly as possible, same as dual zone graft. And then final prosthesis was delivered, and 1 year follow-up. So the study result was so nice. Here, this is a conclusion. Type 1 socket, do immediate implant placement. This is best treatment modality. But when extracting the tooth, a traumatic extraction and preventive extraction should be emphasized. Periotome to cut the periodontal ligament should be prepared. And then horizontal position, labiopalatal position, and vertical position should be considered. And then after placing implant in ideal position, do dual zone graft and seal the soft tissue hole. Immediate provisional restoration delivery is best treatment modality. But type 2 socket, sound labial soft tissue, but buccal bone recession. In this case, do transmucosal GBR. Do immediate implant placement after flap elevation. And do transmucosal GBR with reservoir membrane or smart builder, as we talked in the previous sessions. Type 3 socket, reduce the labial soft tissue and buccal bone. In this case, don't do anything, just extract, and please wait 3 to 4 months until you can get complete soft tissue healing and partial bone regeneration. And then do implant placement along with GBR. Or some situation you can do GBR first and then delayed implant placement can be considered. So this is my treatment flow. So if you can follow this flow, you can maximize the aesthetic result of maxillary anterior implant placement. And thank you so much. In the next session, in the final session, we talked about posterior treatment flow in the posterior area. Thank you for watching and see you again. Bye.